this really gets to the next thing I wanted to ask about, which is some of the really groundbreaking work that you and colleagues did using the population CMS data, looking at how the 2009 trials changed practice patterns. And from this, you end up looking at the mortality benefit, the number needed to treat for vertebral augmentation. It's such an important topic, but for those of us who are not Neiman policy fellows, it's a bit out of some of this is a little bit of our wheelhouse. So can you just explain how this came about and what were the ramifications?
Jacob, it turns out this was a study I really wanted to do, and it's turned into a trifecta of, I think, meaningful publications that are actually often quoted in coverage policies, including the LCDs that the various MACs put out. So in the early days, the proponents of the procedure, again, were coming out of med school at a time where we were taught, I'm actually putting my hand near my hip, which is pretty funny, that patients died after having a hip fracture by, I think it was 2 years, in a relatively higher percentage than you'd think. And the point the teaching, at least back in the 80s when I was in medical school, was it's not the hip fracture, it's all the things that the hip fracture implies and the limitations placed on the patient because of the hip fracture. And many of us wondered whether or not that could be true of a vertebral fracture, just this, again, terribly named fracture, benign, because it was contrasted with malignant, but it was hardly benign in many patients, not every patient. People can get fractures and not be in pain, but in many patients, it really hardly was benign, but it was a mindset that these are benign fractures. If they're just left alone, 6 months later, a patient will be better. Well, tell that to a 92-year-old. I mean, it's in my mind, a sort of cognitive dissonance amongst people that just don't believe in the treatment. When that began to get supported by studies and literature, it was really quite, I think, a great day in the sense that we had slides comparing hip fractures to spine fractures. We had theories based on papers about what happens to your GI system, what happens to your respiratory system. We had lots of ideas, but no proof really of what we were thinking, which is that quite obviously you would think if a person has a compression fractures and terrible pain, but they get to mobilize early, go back to their life, they're not on long-term narcotics in the same way, that would obviously be good for patient longevity. Well, starting with Ab Editon, who was a Medtronic employee at the time, brilliant guy, but employed by one of the vendors, there was a study looking at the CMS database, and it showed pretty clearly that patients treated with augmentation did better than patients who were treated with conservative therapy in terms of survivability. Dr. McCullough, who I don't know, working with my friend Jerry Jarvik, who truly is my friend, he and I were in the same medical center. I think he was a fellow. I'm a resident at the time, or maybe a medical student at the time, taught me so much. They did an article where they took a different database, used propensity matching techniques, and said, yeah, be careful of that observation, Editon, because they didn't say it with that snarl, but I did that for a fact. But be careful of that observation, because when you use these adjustment techniques and actually really, really shrink the population down to be propensity matched, we're not showing the benefit. Now, pre-propensity matching, we show the benefit in our paper. And there is an irony that Editon's first paper, which was published in JBMR, an excellent journal, was then kind of rebuffed by a much smaller paper published by McCullough in a much higher impact journal, I think JAMA Internal Medicine. Editon came back, did additional papers using propensity adjustment techniques. People from around the world came and looked at mortality in their populations. And other than McCullough, the theme was emerging that, well, when you look at claims-based data sets, there does seem to be a mortality advantage. So we had an idea, and actually one of the people involved was your fellowship director from back when you were a fellow. Doug Beal was a part of this. And it was, if the mortality benefit is real, is there a way we can demonstrate that using a similar population examined at different points in time? And whether it was Dave Calmes, I think working with a person named Leighton was the first author, or ourselves, There was no dispute that after the 2009 trials, there was a dramatic drop in vertebral augmentation procedures. Now, if you're Dr. Bookbinder, you're not going to argue with that. You believe that was appropriate. She probably thinks very few should be done right now. If I look at that, I say, wow, think of all the patients we could have treated that were not treated, that this mortality data suggests we've really done wrong by. Like, not even to let the patients have an option to get treated, to have a consultation. I mean, not to trust the patient to have a consultation with a doctor that might be able to perform this procedure, which everybody had seen with their own eyes would, in 80+% of cases, make such a dramatic difference for patients. So our idea was, again, predicated on the notion that augmentation had dropped off a cliff, which, again, is not in dispute, just people view that same reality with a different lens. The idea was, there's this massive database, the CMS database. Let's look at the 5 years before 2009 versus the 5 years after 2009. Now, you mentioned Neiman, which provides tremendous support. It didn't for this particular trial, but it provides tremendous support for looking at these databases. It's a wonderful policy institute, and I am proud to be associated with it. Neiman estimates that between 30 and 35 million patients per year are in the CMS Medicare fee-for-service database. At that time, you didn't have access to Medicare Advantage data, but every year, 30 to 35 million patients are in this. They're different patients, but the concept is it's likely in aggregate, the patients seen from 2004 to 2009, and I'd have to look up because I don't even remember the years myself, versus 2010 to 2014 are similar. It's not that we're comparing a patient to a patient. We're just saying it's the Medicare fee-for-service database. What's the main difference? The main difference is the percentage of patients getting augmentation, and I think we showed it dropped in that group by 40%. We looked at over 2 million compression fractures on that, and at least somebody told me at the time it was the largest series ever looking at compression fractures, which I have no reason to doubt because probably the other biggest series would be pharmaceutical studies, things like that. And I don't think they ever would have been that big. We had over 200,000 patients, I want to say, treated with augmentation of either vertebroplasty or kyphoplasty. And I think it's critical to mention that we use propensity adjustment. And beyond that, we worked with, through the support of Medtronic, who didn't support any of the doctors. This was volunteer work on the doctor's part to do the trial, but that did support PhD level statisticians. So this isn't Josh and Doug doing statistics on the back of an envelope, which I think is important for credibility. But I also think that disclosure is important. I don't know how we would have gotten the support for folks like that without industry support. And the headline news was there was a statistically significant difference after propensity adjustment between the cohorts from pre to post, with what we postulated, the major difference being the percentage of patients that underwent augmentation. And two kind of asides that are not the headline news, but the first was at 10 years, 15% of patients with an incident compression fracture was still alive. So I could talk about stroke. I could talk about stroke with some knowledge. I was going to say I could talk about heart attack with very little knowledge. I could talk about cancer. 15% survival at 10 years, this is a bad disease. We should treat it like a bad disease. It's not a benign fracture. It's benign in the sense that it's not malignant, but 85% no longer with us 10 years later. Can't say that about a lot of pretty bad diseases. So using the vernacular for benign, it's not a benign disease. It's one where I think we want to treat people and treat them properly. The other observation, which you then alluded to in your question, and again with my long-winded answers, I think that question was about an hour or so ago, the number needed to treat. So another observation from this data set was that at every time point across the 10 years, kyphoplasty and vertebroplasty in that order did better than conservative therapy, which again, other than McCullough, was something that had been borne out. The stroke world was in 2015 blown away by these trials that demonstrated really low numbers needed to treat in order to have positive results with mechanical thrombectomy. It's where I really learned what number needed to treat was. We wrote a paper. We published it in the AJNR, number needed to treat to save a life. Interestingly, we chose a much more circumspect title for that paper, like how data might influence randomized controlled trials or something like that. And the editorial group at the AJNR asked us to make this much more provocative title. And in it, and on this paper, by the way, Kevin Ong and his colleague, there was no industry support. They just really were so impressed by how meaningful this result was. They gave us their statistical sophistication, and we looked, and you are correct, about 12 patients. Again, I don't think it really means you need to do 12 kyphos in order to save a life versus not. That's not really what number needed to treat is, but it did say what I think is obvious, that you have a positive impact by doing this treatment. So my friend David and my friend Jerry wrote a pretty aggressive letter to the editor at the AJNR, and I wish those were more commonly seen, right, by people who are reading afterwards, because we had an opportunity to respond. And I thought that dialogue was wonderful because they really tried to rip apart the paper, and I think the title probably is one of the reasons. But in my response, I had the opportunity to dispel every single one of the arguments. And my point back to them was, I tried to learn from the 2009 trials. I studied placebo. I've written about it. I've talked about controlled intervention. I've learned what that means. Meaning, I think there's data. We should have grown from 2009 rather than get into this crazy back and forth about the trials and they mean everything or they mean nothing. We could have learned. The community could have advanced. Isn't it reasonable to have a similar attitude to basically every claims-based data set except for the McCullough one? Meaning every paper that looked at this, including ours, the largest study of compression fractures in history, has demonstrated this survivability advantage. Isn't it possible that it's because it's biologically plausible that getting people off opiates, which by that point were now being realized to be problematic, mobilizing patients, not necessarily requiring that they go on things like anticoagulation for not moving around, not wearing back braces, which can worsen local osteoporosis, at least some of the older back braces. Isn't it biologically plausible? Can't you give us that? In which case, shouldn't we begin to rethink all of this adversarial stuff? I mean, can't patients be given the opportunity with their family to have a consultation and find out if they're appropriate? I don't treat every patient that comes to me for compression fractures. There are people I counsel to do conservative therapy because they're going in the right direction or for whatever reason. That's a mature dialogue. That's how we advance patient care. The last thing I wanted to do with that kind of data set, which again, I was very, very proud of, was to see how it fit into the world's literature. So working with some brilliant folks from Australia and a lead author named Hindi, we studied through meta-analysis techniques the entire literature on mortality benefit. We had German papers, I think Thai papers, the CMS paper, so from really around the world. And the bottom line was that I think we found a 22% survivability benefit across the world's literature, with the Ong paper actually having a lesser impact, meaning we brought down the numbers. I want to say two last things about this. Jack Jennings penned, we're at ASSR, first MSK president of ASSR a number of years back, a simultaneous commentary, and he made the point, we should stop talking about mortality benefit like it's a question. There is so much data out there. He said it's level 2A evidence, and I thought, wow, Jack, you're making a really, really key point, that we keep talking about the mortality benefit as if it's something that needs to be studied and studied and studied. Meanwhile, on the basis of about 200 patients in Invest and Bookbinder, we totally upended the entire world. I'm not arguing the mortality benefit is everything and anything. I'm just arguing it should be considered. And when you say it's level 2A data, it wasn't subjected to randomized controlled trials, I think that that's an important point. The other point is, as someone who learned kyphoplasty early, stuck with vertebroplasty, then became a hybrid user where I was doing some vertebroplasty, some kyphoplasty, the publication of the Ong paper really changed my practice such that I mostly do kyphoplasty, really probably 95+% of the time. I'd have to look to see what percentage I do vertebroplasty. because the mortality benefit for kyphoplasty was greater. Again, subjected to propensity adjustment. And when we would publish, or when we tried to publish, you would see the reviews. You could tell that some of the reviewers were vertebroplasty proponents who loved the paper, but would say, I just don't believe it with vertebroplasty versus kyphoplasty. Other people didn't like the paper. They didn't believe it at all. And I said, well, I don't believe that the vertebroplasty practitioners who I understood, I had come from that community, who are saying, I just don't believe it with respect to vertebroplasty. I don't think they're being fair. You can't say I love the message, but then I only like the portions of the message I like. So if I really believe this mortality benefit, then I owe it to my patients to do the therapy that gives them the greatest opportunity for improvement with the technique that they're letting themselves be subjected to, and that's kyphoplasty. So in my practice, these papers have helped me evolve such that I predominantly do kyphoplasty in the vast majority of times. So not even predominantly, I basically do kyphoplasty. It's fairly uncommon for me to do vertebroplasty at this point.
Mm-hmm. Mm-hmm. I'd agree with that. And I think that the use of vertebroplasty does still have a major benefit in certain situations. And we're actually planning to have another episode where we're going to discuss the situations in which you may consider one option or the other.